So thank you very much, everyone, for coming to the second Diabetes Masterclass. I'm Harriet. I'm a diabetes and endocrine trainee and also a training rep for diabetes and endocrine regs within Northwest Thames. So we've got 3 sessions today. The first speaker is Dr. Will Howson, who's a consultant gastroenterologist at Imperial, who works closely with our diabetes service. And he's going to talk to us about strategies in the management of gastroparesis and diabetes. So thank you very much, Dr. Howson, for coming to speak to us today, and over to you.
Thanks very much, Harriet. Very kind of you to invite me. So I'm going to talk a little bit about gastroparesis and diabetes. So I've got a case that I'll present briefly, a very brief review of the literature, and a little bit about the sort of pathology of it.
Sorry to interrupt, Dr. Howson. So I can only see you, I can't see your presentation. I don't know if you've stopped.
Unshared. Let me see if I can share again. Can you see this? Is that better? Perfect. So I've got a case that I'll present briefly, a quick look at some of the literature and some of the clinical pathways, a little bit of research, and I'm very happy to have discussions. So if you'd like to ask questions during, then Harriet's going to moderate for us, and then if you'd like to hold any questions to the end, I'm very happy to take any questions at the end as well. So this is a fairly typical patient that we see in a clinic that Nick and I run together. This is a female patient born in 1982 who was diagnosed with type 1 diabetes aged 12, and she had pretty poor control at that time. She had a ureteric stent for recurrent UTIs and had long-standing glucose that was well above target. She's developed some sort of fibromyalgia type symptoms as well, and anxiety, and then developed some harder diabetic complications with evidence of retinopathy and bilateral laser photocoagulation. She was referred to Imperial for consideration of insulin pump therapy around 2013, and then started on insulin pump and developed really quite good glucose control following this, with HbA1c of 58. In 2016, she developed severe constipation with watery stool and urgency, which is what we classically see as sort of overflow diarrhea. She had a hydrogen breath test, and then this is quite a nice picture here of a shape study. So what you do is you get the patient to take capsules containing metal shapes over the course of 3 days, and then on the 5th day you take an abdominal X-ray, and as you can see, there are different shapes. So there are rings and circles and squares, and she has these distributed all the way throughout her large bowel, consistent with slow transit constipation. So she was treated with a combination of magnesium hydroxide and Dulcolax and domperidone and erythromycin, and sort of carried on from there. By 2018, she'd gone through a sort of a full lineup of most of the drugs that we use for constipation. So bisacodyl is a direct stimulant, precalipryde's a 5-HT4, prokinetic, domperidone, another prokinetic, erythromycin. She had prokaryotics, she had linaclotide, which operates on chloride channels, and levoprostone. But she still had ongoing discomfort, intermittent alternating constipation, diarrhea, and bloating associated with it. By 2020, she'd gone to Peristeen, which is an irrigation device for constipation, and actually that controls her constipation reasonably well. But she then went on to develop persistent bloating, belching, nausea, and reflux despite being on domperidone. She made herself vomit, which made her symptoms better. She then had, I don't quite know where she had a single phase rather than a dual phase emptying study, but had an emptying study that was consistent with the T half of normal, but only 69% of the tracer emptying by 1 hour, consistent with some delayed gastric emptying. Her HbA1c was pretty good. Her weight was stable, although not particularly raised, but she found her symptoms very, very disabling. And she's got significant psychological impact. She had an OGD, which is unremarkable, and a trial of rifaximin, which we do as a trial to see whether you can treat bacterial overgrowth. And then went on to have a proper dual phase emptying study that was entirely consistent with gastroparesis, with only 93% of the ingested liquid emptying at the end of the study, and T half with semi-solid meal, 94 minutes, 7 minutes rather. So the question is, what next and what's going on? Is this similar to patients that you'd see in your practice regularly?
Yes. The only thing I think that maybe slightly flummoxed me was the presentation with severe constipation. And I just wondered how frequent that is in comparison to specific upper GI symptoms, vomiting and bloating.
So I think we definitely see a combination of dysmotility in general, and constipation is something that we do see. You also, as you'll know, you often get a sort of autonomic type diarrhea. It's often very difficult to differentiate between the two, and history can be really, really helpful. So in constipation, people generally tend to have alternating diarrhea and constipation with proper urgency and overflowing continence, whereas autonomic diarrhea tends to be just more consistent all the way through. But the two do go together, but they can be fairly erratic as to which one presents.
You mentioned that she'd had the single and dual. Had a single phase, but actually you need a dual phase. Is that correct?
The dual phase is preferable. That's right. So the phase is to do with the phase of what's taken in, and as I'll talk about in a little bit going forwards, the liquids and solids are processed differently by the stomach, and generally liquids are better tolerated, but it's useful there to have a dual phase to confirm the presence of gastroparesis. So gastroparesis is relatively common. It used to be very common in type 1 diabetics, and studies in the 1980s show that about 60% of people had symptoms consistent with gastroparesis. The glycemic control has improved, it's probably changed, but it's somewhere between 5 and 40% of type 1 diabetics will have a degree of gastroparesis. The risk is unsurprisingly greater in type 1 than type 2, and it's more common in women than men. Risks associated with increased age. There are some gastroenterologists who will tell you that you can't be young and have diabetic gastroparesis. I think that's absolutely not true. A lot of it depends on how bad the HbA1c has been and how many complications there are. But certainly the incidence does increase with age and increases with greater deprivation as well. Other GI symptoms, including diarrhea and/or constipation, are both common as well. And given the underlying mechanism, that isn't that surprising. And it can be associated with early post-meal hypoglycemia. But the most significant thing for the patients, and certainly for this patient, is the high levels of anxiety, depression, and reduced quality of life associated with it. I think eating is a very fundamental thing to who you are and how we behave as human beings. And anything that affects that, I think, has a significant effect on people's quality of life. And if you get to a stage, like as this patient had, where you become very anxious about eating anything at all, because you're concerned that that's going to trigger your symptoms, I think it becomes very, very disabling. There's a slightly busy slide that I've stolen from one of the endocrine reviews. I think the important thing to remember is not everything that goes on here, but that the innervation of the gut is really quite complicated. You have input both from the sympathetic and the parasympathetic pathways. The vagal nerve has a very significant input on gastric emptying in general, but also on the whole of gut motility. The whole pathway, as you probably remember from your medical school days, with migrating motor complexes, starts in the stomach and then migrates down with food, and is fairly closely controlled both by input from higher up, but also from local effects of the enteric nervous system itself, with excitation and inhibition of motor complexes to move things down through the gut. stomach's not just a tube. I mean, it's nice to think of it as just being a tube, but it really is the point where digestion begins. So as food's presented into the stomach by the esophagus, it produces chyme. It breaks down the food by its coordinated movement, and it also regulates the passage of nutrients into the small bowel as well. So it's got propulsion effects, it's got relaxation effects, and it's got a compliance effect as well. And these are what tend to affect the different presentations of gastroparesis. So there could be failure of the motor complexes, so food can just sit there and pool and not be emptied properly. There can be a failure of relaxation, particularly at the pylorus, which means that food gets trapped in the stomach. And then there can be a reduced compliance in the stomach with increased distress and discomfort, and that which tends to cause more of the bloating and dyspepsia type symptoms that people with gastroparesis experience. I think the feeling in the gastroenterology world is that the lack of characterization of this is the result for lots of the studies that we do not being positive. Is that if gastroparesis is the symptom, but it depends whether you've got lack of coordination of the propulsive waves, whether you've got failure or relaxation of the pylorus, or whether you've got just a decreased compliance and pain sensation as a result of distension of the stomach. And that's that sort of is the different symptoms that people tend to present with it, rather than it just being a blockage of the outflow of the tube, which means that things don't work properly. So the mechanism for diabetic gastroparesis is both on the autonomic nervous system and also on the enteric nervous system. So you lose excitatory and inhibitory nerve fibers, so you get lack of coordination of the propulsive waves, and then you lose these cells, the interstitial cells of Cajal and the enteric neurons from the enteric nervous system. And together these have effects, both meaning that things fail to relax because you lose inhibitory effects, and also failure of organization, so you get disordered movement through. What's one of the things that ties in as well with, as you saw with this first patient, she was given a course of rifaximin, and if you have pooling in the small bowel, discoordination of small bowel motility, that's when you tend to get changes in the microbiome occurring within the small bowel, and that can then exacerbate symptoms further and change motility further. So for me, small bacterial overgrowth, which is something that we see relatively frequently, always triggers for me an attempt to try and find out whether there's an underlying cause of motility disturbance, diabetes obviously being a common one. The other thing to really recognize, and I guess I don't need to tell a bunch of diabetologists this, is that there's a bidirectional effect of hypoglycemia. So as the hypoglycemia becomes worse, it tends to slow gastric emptying further, and the gastroparesis seems to make the hypoglycemia worse as well. So it's really, really important that the first thing that we try and do is to try and sort out the diabetes side of things, to see if we can improve the symptoms significantly. So there's an association between higher glucose levels and impaired gastric emptying, and glucose controls. It's been really critical for management. I think, as we were discussing before we started, that insulin pumps have obviously been a big change, but we see that people on insulin pumps seem to have a much better symptoms in the first instance. Although it improves the symptom score in studies, it doesn't seem to significantly affect GI function, which is interesting. And so it's one of the major things that we do in the first part of our management in the MDT clinic with investigation, is to try and get people's glycemic control as good as possible. And I'm obviously very lucky to work with Nick, who's extremely good at doing this and managing these patients. The history is really, really important. So I think it's important that you recognise what the diabetes history is. I'd be very suspicious if someone presented young who's had very, very good control their entire life, whereas I'd be much more suspicious if someone presents later on with evidence of peripheral neuropathy or renal disease or eye disease. The nature of the vomiting can be quite useful as well. Cyclical vomiting syndrome, CVS, is certainly one of the differential diagnoses in these patients. And in CVS, you tend to get much more episodic vomiting, so it tends to occur very severely for a course of 3 or 4 days, or possibly even a week, and then so often associated with very poor glycemic control. But if you ask the patients here, the glycemic control gets worse after the vomiting begins rather than the other way around. So it's not normally that patients have poor glycemic control and then begin to vomit. It's normally the other way around. And there are certainly some of these patients who we see in clinic and have managed with the sort of classical management for CVS as opposed to for gastroparesis. I think medication is really, really important. In particular, opiates slow gastric emptying in the same way that they slow the gut in general. And it's really important that you take a good medication history and try and stop drugs that are likely to slow gastric emptying. There's quite a lot of discussion about tricyclic antidepressants, because we know that they do also slow gastric emptying, but they have been used and are still recommended in the American guidelines for gastroparesis. I think I tend to be slightly cautious with them and see how things go, but a good medication review is really, really important. I know that cannabis is terribly trendy at the moment and supposed to be a sort of cure-all for everything, but there is no doubt that cannabinoid hyperemesis syndrome exists and is associated with cannabis usage. The important thing about this is that patients will tell you that they've given up cannabis for a couple of days and the vomiting didn't get any better. It's a much more chronic thing than that, and you need to give up cannabis for 2 or 3 months to see whether that improves symptoms or not. And obviously, we're dealing often here with young patients and sometimes young men who may have addiction problems. And it's something that we've had to explore a few times about cannabis usage and trying to get people to stop. And people are, particularly given the current press, often very resistant to stopping cannabis. And then we also ask about other GI symptoms and other autonomic GI symptoms. And as I say, gut motility is, unsurprisingly, given what I've told you about what the underlying mechanism is likely to be, is it's quite common, but it can be associated with diarrhea, it can be associated with constipation. The important things, I guess, for us are weight loss, because although quality of life is poor, the thing that obviously becomes dangerous if people are unable to maintain their weight because they're vomiting so significantly, and that may require us to be more aggressive and consider alternative routes of feeding. So it's something that we watch fairly carefully, and we continue to watch the patients even once we think that we've got them reasonably well under control. And then Nick is obviously an expert in diabulimia, or I thought we should call it insulinorexia. Seemed much more sensible to me, but apparently that's not what it's called. And if you talk to the gastroenterology world, then it's something that they think is very important. And I'm very lucky, and it's not something I need to consider terribly carefully because I've got good access to Nick and the psychology support that he has as well. But it certainly is a problem. So what investigations we recommend? Well, I think everyone who comes with recurrent vomiting should have an OGD, and that's to exclude any other anatomical cause of the problems. Gastroparesis, you wouldn't really expect to see anything very significant during the OGD at all. It should look absolutely normal. But the thing that we often find is that there's large residue of food in the stomach, and it requires a prolonged fast. That's been a real problem in the past because it means that we've had to admit people for prolonged fast on the wards on the sliding scale. And as I'm sure you all know, patients on the sliding scale often end up not being particularly well managed on a general medical ward. It's much, much better with insulin pumps. And certainly with the first patient we had, she did her a 48-hour fast at home using her insulin pump, which worked very, very well for her with just liquid intake, and that's worked very, very well. And I think will make our lives as gastroenterologists easier, having had a number of patients where I've done a standard OGD, then had to admit them, and then still have significant amounts of gastric residue and very poor glycemic control. And then a gastric emptying study, which is done with a 99M technetium meal, and you can see here that on the left, the image, so you have a gamma camera that takes the images of the stomach, over the course of 3 or 4 hours. And you can see that you should be having a good amount of emptying. And on this one, you can see that the T0, the levels don't drop at all. So what's the management? So the first thing is to try and improve glycemic control as much as possible. We then review the medication. Opiates are the really significant thing we try and stop. They are often prescribed if people have got a pain predominant symptoms. So with severe dyspepsia, I think that it's getting better now. I think there's much more awareness of opiates, but previously we not infrequently see people who've been on opiates for their pain associated with gastroparesis, which has then made their gastroparesis worse and didn't really do anything about their pain. And TCAs might consider at that stage whether they're being helpful or not. There's very good evidence for dietetic review and eating small meals regularly with small particle size. And it's probably the mainstay of non-interventional treatment. And then prokinetics. So metoclopramide, as you know, works reasonably well. There is the issue of tardive dyskinesia, particularly in young women, and it doesn't seem to work as well as domperidone. The issue we have with domperidone is to do with the QT interval, so it's not licensed in the US at all, and has to be used off-label there. In the UK, we are still using it with fairly careful advisory. So we review the drugs and make sure they're not on any other medication that we prolong QT, and then do a screening ECG at that stage to make sure that they're not already in prolonged QT before starting domperidone. But it does seem to be the drug that seems to work the best for most patients. Erythromycin works okay. It tends to work short term, and then the tachyphylaxis means it tends to stop working. So it can be good to use it and then have a break from it. It's often quite good for the patients with constipation. It seems to work reasonably well for them. Precalcipride is a newer agent and was originally marketed for constipation, but there's no doubt that it has an effect on gut motility, pan gut. And we've managed a couple of patients who had constipation and gastroparesis quite effectively with precalcipride as well. And then there are newer agents coming through like remorenin, which is ghrelin agonist rather, which there's some hope that there will be things coming through, although interestingly the phase 3 studies seem to have been stopped, so it may not have been as effective as we promised it was going to be. Antiemetics are the next sort of mainstay treatment as well. Prochlorperazine works reasonably well. Cyclizine also works well. The issue with cyclizine is that it gives you, as you may or may not know, a low-grade high. So there can be a lot of patients who will announce they can only take cyclizine rather than anything else. Ondansetron's difficult. Ondansetron, we know, slows down colonic motility. So it's an unlicensed treatment for chronic diarrhea and IBS-D. There's some feeling that it may work for gastroparesis, although the studies aren't convincing. In general, I have to say I'm not a great fan of it, because I think if it's slowing down lower gut motility, it's likely that it's going to be having an effect on upper gut motility as well. So we do see it used because it's obviously the strong antiemetic that everyone likes giving, because if you have a patient in front of you, you can't think of anything else to do. Ondansetron is a reasonable final step. But we have tried some patients to try and stop it to see if we can improve. And interestingly, the patient who had presented as a case was on ondansetron, and that certainly was worsening her constipation and making her quality of life worse. Then there are endoscopic treatments. So the evidence for botox isn't very strong, unfortunately, and I think this comes back to the thing I was saying at the start about how gastroparesis isn't a single thing. It depends whether you've got disorganization of your motor complexes, or whether you've got failure to relaxation of the GOJ. The pylorus rather. There's no doubt that some patients, when you inject Botox, have a very, very strong effect. There's also no doubt that the RCTs done with sham didn't show statistical significance. I think every gastroenterologist who encounters these patients probably will do a trial of Botox, because if it has a significant effect and it's prolonged and lasts 6 months, it's a relatively low intervention, low complex intervention. Dilatation is the same thing, but just slightly more complicated. So you put a balloon into the pylorus and dilate it up with the aim to fracture the muscle fibers of the pylorus, so that it's going on continuous, so that it's unable to contract and slow into gastric emptying. And then GPOEM stands for gastric per oral endoscopic mucosector, myotomy rather, and it's an endoscopic resection technique to cut the fibers in the same way that dilatation breaks the fibers. There's been a lot of excitement about this, and certainly for achalasia, it works very, very well in the distal esophagus. I think it's beginning to become clear that it probably doesn't work as well for gastroparesis, and really at the moment people are only offering it on a trial basis. Patients with long-standing problems, gastrojejunostomy can be helpful. I have to say it's a fairly significant thing to do. And then for those patients who have gut failure and are losing weight despite all of the treatments, then a number of them will end up on parenteral long-term parenteral nutrition. It's important to remember that other symptoms can present as well, and so we see quite a lot of patients with diarrhea. Before, I think we would have all assumed that it was just autonomic dysfunction, but actually going through our normal sort of gastroenterology interventions for diarrhea, we found a number of people with this condition of bile acid diarrhea, where bile acid and your enteric, hepatoenteric circulation, you have bile acids which emulsify fats and would then reabsorbed in the distal small bowel. If you lose the feedback pathway for that, the bile acids go into the large bowel, where they have a significant osmotic effect and cause osmotic diarrhea. We've been looking to see whether we can find any evidence of people looking at that, and there's nothing really since 1978 saying whether or not that there's an association between type 1 diabetes and bile acid diarrhea. But we certainly have seen some patients with very severe symptoms who've responded well to bile acid sequestrant. The other thing is pancreatic exocrine insufficiency, and I suspect there are a group of patients who have type 1 diabetes secondary to a degree of autoimmune pancreatitis, and these patients often will have low fecal elastase, which is the test that we do in-house for this. It's the one problem with that as a test is although it's quite sensitive, it's not very specific in people with high volume diarrhea. We often just end up trying the trial of Creon, which is the enzyme supplementation, to see if that works. And then I guess the final thing is that there are some number of people who have autonomic dysfunction, and they can be very difficult to manage. So we don't, beyond trying to improve glycemic control, don't have necessarily a way to try and reverse things specifically. And then, as we discussed with the patient at the moment, that slow transit constipation can also be something else that we can see. And lots of the treatments are similar to the treatments that we try for gastroparesis, particularly about trying to avoid drugs. We use more stimulants, so bisacodyl and senosides, and also volume increasing laxatives, so things like Movicol. I'm not a big fan of lactulose because it tends to be broken down and fermented in the small bowel and can cause people quite significant cramping abdominal pain. So I tend to prefer using Movicol rather than using that. So with this lady, what we did was we gave some Botox to the pylorus, and you can see this is the picture afterwards. So that sort of rose type thing in the middle is your pylorus, and you can see that there's 4 puncture marks where I've injected Botox into it, and that's why it's quite so prominent and sticking out. And she had really quite significant symptom improvement following this. So her vomiting has reduced, but she's got ongoing bloating. I suspect that the bloating is probably associated with some of the other symptoms in her gut, as well as simply the gastroparesis, but this has allowed her to eat slightly more effectively. And the next stage will be to consider doing a balloon dilatation to break the fibers to see if we get long-term response to this. I'm very happy to take any questions if that's anyone has anything they'd like to ask.
Can I just ask, so you mentioned in the case that lady was on rifaximin for small intestinal bowel and bacterial overgrowth. How concerned do you get about the risk of bacterial overgrowth in these patients?
So as I say, I think bacterial overgrowth is something that we think about. I think it can present in a lot of ways, and I think particularly in patients with lots and lots of diarrhea, it's certainly something worth thinking about. The test traditionally for it is to do a breath test with a hydrogen breath test, labeled hydrogen, to see whether the carbohydrate is broken down in the small bowel. So I'm not so convinced. There are gastroenterologists who will tell you that this is the final stage of all IBS, and that if you treat bacterial overgrowth, a lot of patients will get better. That's not really my experience. I think if people who have, like this lady, strong evidence of dysmotility, I think it probably is helpful. I don't think that it's necessarily helpful in patients who don't have similar evidence.
There's a question about the role of pregabalin or gabapentin for pain associated with gastroparesis.
Yeah, I think they can be helpful. I think I tend to use them in preference to tricyclics on the basis that tricyclics are supposed to delay gastric emptying. So yes, I think that there is a role for them as well.
Okay. Does anyone else have any questions? Feel free to unmute yourself or post in the chat. Rong, do you want to go ahead? Chong, did you have your hand up? I don't know where he's gone. Can I ask another question? I don't know if this is something that I probably should know, but why does early meal or early post-meal hypoglycemia increase the risk of?
I'm not sure I know the answer to that either. I think it's to do with the response to. No, I don't think. I'm not sure I know the answer to that either. It's Kareem will know.
I'm not sure he's listening. Chong, did you have a question?
No, I'm sorry. I pressed the button by mistake. Sorry.
That's fine. Okay, so it looks like there are no other questions at the moment, but thank you very much for such a detailed overview.
No problem. Thank you.
Okay, so our next speaker is Parry, who is a diabetes and endocrine trainee. She's going to give us an update on diabetes technology. So again, thank you very much, Parry, for running this session. And if you're happy to share your screen and just let me know when the questions are coming up, and I will run the Menti.
Perfect. Thanks very much, Harriet, and good afternoon, everyone. It's good to know that chocolate and salted caramel are winners of the ice cream competition. So I'm going to be talking about some of the advances in type 1 diabetes technology, and I'll be talking a little bit as well about inpatient use of these newer devices. Very happy to take questions as we go along as well, or at the end. So I'll be covering a bit of background about type 1 diabetes, insulin pumps, continuous and flash glucose monitoring systems, as well as hybrid closed loop systems and how they're managed in hospital. So type 1 diabetes is common. More than 350,000 adults in the UK have type 1 diabetes, but only about a third of individuals will achieve optimal glucose targets. And we know from the DCCT trial done back in the 90s that with increasing HbA1c, there's increased risk of microvascular complications, that is with retinopathy, nephropathy, neuropathy, as you can see from the graph on the bottom left. And then as HbA1c is reduced, there's an increase in the risk and rate of severe hypoglycemia. And severe hypoglycemia is really the barrier to optimal glucose management. Individuals on average can have up to 2 self-treated incidences per week of hypoglycemia, and then up to 3 episodes of severe hypoglycemia, so that is requiring third-party assistance annually. And these recurrent episodes of hypoglycemia that an individual may have can essentially erode into one's awareness, causing impaired awareness of hypoglycemia, and that in turn becomes a perpetuating cycle, increasing the risk of further severe hypoglycemia as well as mortality. And up to 1/3 of individuals may have impaired awareness of hypoglycemia. And the diabetes digital landscape over the last decade or so has really changed, as most of you will be familiar with. Certainly in terms of glucose sensing technology, we've moved from standard finger prick glucose monitoring to now newer device technologies, which include flash glucose monitoring and CGM, which I'll talk about, that are now able to wirelessly transmit data to either a smartphone or a smartwatch. Insulin delivery systems as well. There have been standard insulin pens that we've been using, and now there are smarter pens on the market, as well as continuous subcutaneous insulin infusion, so insulin pump therapy. And we'll we'll talk a little bit more about that as well. And then finally about data management. So individuals used to record their blood glucoses in books, and now that data can automatically be transmitted, providing huge amounts of data that can provide reports on ambulatory glucose profiles as well. So insulin pump therapy. So this was the first insulin pump that was made in the 1970s. It was known as the Biostarter, and it was really essentially just to treat DKA. And you can see that the insulin pump there's almost the size of a microwave oven. And we've come a long way from there really to much more slicker and sleeker devices. So just to go through the components of an insulin pump itself, you've got the pump, which then contains the insulin reservoir, the battery. There's an inbuilt bolus calculator that can help individuals calculate how much insulin that needs to be administered at meal times based on the amount of carbohydrates that they're eating. And then pre-programmable settings, which include the basal settings and bolus settings required for each individual. And then you have the insulin set tubing, and then finally the cannula that infuses the insulin subcutaneously. And really the advantages of insulin pump therapy can be multifold. So certainly some of the things that it allows individuals to do is it can vary the basal rates. And the reason for that is because through insulin pump, you're getting a small amount of rapid acting insulin, so usually NovaRapid, on an hourly basis. And those rates can be adjusted through the day. Individuals can set a temporary basal rate as well. So for example, if they were to go to the gym, then their basal rates can be reduced if required. There can also be a temporary suspension of these bolus of basal rates, as well as altered bolus pharmacodynamics. So what that means is individuals typically will have a bolus of insulin at meal times, injecting their insulin for their meal. And that gets given in a very standard profile, whereas through a pump, you can extend the waveform, so you can give it over a certain period of time, or you can dual waveform it as well if needed. And then finally, fewer needles as well. And there's a lot of studies that have been done comparing insulin pump therapy with multiple daily insulin injections, that's MDI, and we can see that overall HbA1c is favored with insulin pump therapy, and also with improving hypoglycemia. So managing insulin pumps in the inpatient setting. So I have a question, and we'll bring this up on Mentimeter as well. So Tina is a 26-year-old lady who has known type 1 diabetes, and she uses an insulin pump. She presents to ED feeling unwell, and on initial assessment, her pH is 7.19, her sugars are 24, and her ketones are 3.4. So what would you like to do? And the options are, you could switch her to a basal bolus regime, start her on a fixed rate insulin infusion and remove her insulin pump, increase her basal rates by 20% and give her a bolus of NovaRapid via the pump, or increase her basal rates by 40% and give her a bolus of NovaRapid via the pump, or do nothing. Okay, so yeah, excellent. So absolutely, she is in DKA. Here, the main thing would be to start on a fixed rate insulin infusion and stop the insulin pump. Perfect. So unless individuals are incapacitated, and there are a few select situations where individuals should not be using a pump, essentially most people coming into hospital using a pump are usually safe to remain on an insulin pump therapy. However, so you can allow for self-management. However, if they are unconscious, confused, or incapacitated, or if they are in diabetic ketoacidosis, as we saw in the example above, or they're going to have a major surgical procedure under general anesthetic, which is going to last for more than a couple of hours, then they should be taken off the insulin pump. And that's based on the DTN guidance, which I will go through in more detail as well. So essentially, the initial part of assessment is going to be assessing an individual in terms of, firstly, are they well enough and able to self-manage? As part of any individual coming into A&E, check their sugars, their blood ketones, and their pH. You want to assess whether they're in DKA. And if they are in DKA, then really the main thing is start a fixed rate insulin infusion using the standard DKA protocol and remove the insulin pump and tubing if possible. What is important to note here is to unclip the device, so unclip the cannula itself. And the reason for that is because you don't want to snip the tubing itself. By cutting the tubing that we saw earlier, if there's any insulin within the tubing itself, you don't want it to infuse through really quickly into the individual because that can cause hypoglycemia. And then once the pump and the tubing is removed, keep the device safe. Either give it to the individual for safekeeping or a relative, or put it in a box and store that. And it's just worth noting that these devices cost up to £4,000. So definitely it's not something that wants to get lost. Then if the individual is well enough to manage their insulin pump on their own, then they can continue to manage that, but review it in a couple of hours' time just to ensure that things are going okay. If they're not in DKA, not in hypoglycemia, but they're generally unwell, not really eating and drinking, and not really able to manage their pump, the safest thing here to do would be to start an alternative insulin source. So that is either going to be intravenously, so a variable rate insulin infusion, or subcut insulin, so switching them back onto a basal bolus regime, and keep the insulin pump and tubing safe. I think it's worth highlighting that anyone that we're removing an insulin pump for in hospital, I think they're at extremely high risk of inpatient DKA or hyperglycemia if there's any interruption to their insulin delivery. So it's really important to make sure that whoever who's coming and bringing on or starting the insulin infusion, that it's done in a really timely fashion. And if an individual is having hypoglycemia, so a sugar of less than 4, then treat as per standard hypoglycemia guidelines. If you're able to treat that hypoglycemia successfully, then great, you can restart the pump, and it may need to, the pump settings may need to be reviewed. But if the hypoglycemia persists for a couple of rounds after hypo treatment, then again, you should be looking at starting an alternative insulin source. So that would be either a variable rate insulin infusion or subcut therapy. And that's the full DTN guidelines. So continuous glucose monitoring in CGM. So these are devices that measure interstitial glucose. So this is not capillary blood glucose, but interstitial glucose. And the sensor itself sits subcutaneously and is able to transmit a blood glucose reading every 5 minutes to a smartphone or a reader itself. And really the advantages of these newer devices is that it can assess the direction and direction in which glucose levels are traveling in, but also potential fluctuations that individuals may have, and can provide trends as well as alerts and alarms for any impending hypoglycemia or hyperglycemia. So that is 20 minutes before an individual is to go low, CGM can alarm and inform the individual itself. And these, all this data can be transmitted and essentially can provide an ambulatory glucose profile that then we can look at, as well as times and ranges, which can be really helpful. So Ali is 26 and he has type 1 diabetes, and he attends the clinic wearing CGM, real-time CGM. What would be the target percentage time and range for him? So this is between 4 and 10 millimoles per liter. What would be the target that we would be aiming for? And he doesn't have any complications with hypoglycemia or anything like that in the past. So the options are greater than 60%, greater than 70%, greater than 80%, greater than 90%, or greater than 95%. Okay, so great. So most of you got that right. So it is greater than 70% would be the target percentage time and range. Great. So I think most of you may be aware, but there's an international consensus on percentage time and ranges that was published by Battaglino et al. Back in 2019. And for individuals with type 1 diabetes, and this is assuming that they're not at high risk or they're not elderly, then the percentage target time and range, that's between 3.9 and 10 millimoles per liter, is greater than 70%. I'm not sure if you can see my cursor, but this is the diagram here on the far left. So we'd be aiming for greater than 70% for between 3.9 to 10 millimoles per liter. And then less than 3.9 millimoles per liter, the target time is less than 4%. The ranges are slightly different for those who are at higher risk or if they're elderly, and the pregnancy target is slightly different. But I think one thing that I really did want to highlight at this point here is that this is within the outpatient setting. So this does not stand for individuals who are being managed in hospital and who are using CGM. We shouldn't be aiming for targets as tight as greater than 70% because of that risk of hypoglycemia, particularly whilst they're unwell. There isn't any guidance at present in terms of what ranges should be for people who are in hospital in terms of their percentage targets. However, the JBDS inpatient group are writing guidelines that will be available later this year, hopefully, that may shed some light on the percentage target times. And really the advantages of CGM, and there's an overwhelming amount of evidence out there, is that CGM use can result in a reduced HbA1c, reduced exposure to hypoglycemia, improved quality of life. And that's been seen as a benefit for individuals in all age groups, as well as for those who are using multiple daily insulin injections, as well as pump users, and those who've got impaired hypoglycemia awareness. But it is important to note that individuals need to be using the CGM and having the right education to really be getting maximal amount of benefit from these devices. So flash glucose monitoring, and this is intermittently scanned CGM. And this also measures interstitial glucose. And I'm sure many of you will be familiar, so I won't spend too long, but essentially the sensor sits at the back of the arm. In order to get a blood glucose reading, the user needs to swipe the reader, and data can be stored retrospectively for up to 8 hours. Libre 2, which is now available on the market, can also provide an alarm if someone is in hypoglycemia, and there's also a hypoglycemia alarm. However, Libre 1 didn't have these. We still have a lot of individuals who are on Libre 1, so I think it's worth knowing the differences between the two there. And really, this is just a table about a comparison of all the devices on the market. And I think this is a really rapidly evolving field. I mean, since this table was published, we now have the Guardian Sensor 4, which does not require any calibration. So these are the Medtronic CGM sensors. There's Dexcom G7 that's been recently announced. And also there's Freestyle Libre 3 that has been approved for use, but still not available in the UK. And just a quick update in terms of the NICE guidance that was published last month. So the new NICE guidance states that flash glucose monitoring or continuous glucose monitoring should be available for all adults with type 1 diabetes. And I think that this is really an exciting and really important step for individuals with type 1 diabetes, because it is a huge burden in terms of all the glucose monitoring and insulin delivery that's required from individuals. And flash glucose monitoring will also be offered to people with type 2 diabetes who are on multiple daily insulin injections if they have any complications of either recurrent or severe hypoglycemia, impaired hypoglycemia awareness, or a condition or a disability that means they can't self monitor. I think it's worth mentioning that the NICE guidance was published last month. It will really definitely take a while before it can be fully implemented for all individuals. And certainly we are going to, as endocrinologists and diabetologists on the group here, definitely there's going to need to be some thought about how that's going to be implemented to the wider cohort, and how we're going to be able to provide that appropriate level of education that goes with giving the technology itself. And I do think that it is really important that the individuals who would have met the criteria based on the 2015 guidance do get that technology, early, because there's still people out there who are not yet established on either flash or continuous glucose monitoring. So glucose sensors in hospital. There's not really much to say here because there are no clear guidelines at present. As I mentioned, the JBDS Inpatient Society is going to be hopefully publishing some guidance later this year. If an individual is in hospital and they're unwell, hypotensive, on a fixed rate or a variable rate insulin infusion, then they must have standard capillary blood glucose monitoring. However, if they're well, stable, and able to self-manage, then they may use their own sensors, that's either CGM or flash glucose monitoring. And usually there's always someone from each hospital who will have some diabetes technology experience or expertise that can be contacted. And then finally, I wanted to talk about combining pump and CGM technologies. And I think it's really important, as again, diabetologists and endocrinologists within the group. I'm sure you all will have seen the headlines in the BBC News about the artificial pancreas essentially revolutionizing diabetes care. And I just wanted to talk a little bit about the combinations of pump and CGM, and then I'll come on to the artificial pancreas system. So really combining a sensor and a pump will allow for a sensor augmented pump. And then the early generations of these allowed an algorithm to essentially have a sensor augmented pump where the insulin delivery through the pump would be suspended when the blood glucose would be low. So when it would drop less than 4, the insulin, basal insulin would be suspended. And then the next generation of this would essentially allow for sensor-augmented pump therapy with insulin suspend before the blood glucose drops. So that is in the context of if the CGM sensor was to detect impending hypoglycemia, so that was 20 minutes prior to the hypoglycemia, insulin suspension would be suspended. And those are the predictive low glucose suspend systems. And we know that predictive low glucose suspend systems compared to sensor augmented pump therapy can certainly reduce the time spent in percentage time in hypoglycemia. And so finally, coming on to this artificial pancreas, which I think ideally is, what research is really aiming for, where I think it completely takes over and you can have a fully closed loop insulin delivery system. But I think that the important thing really to say here is that it's not yet a fully closed loop system. These are what are known as hybrid closed loop systems. And these devices, or algorithms rather, are certainly very advanced. So in addition to the predictive low glucose suspend, so these are all the newer closed loop systems that we have that are available on the market. In addition to the predictive low glucose suspend, you also get an increase in the basal insulin in response to hyperglycemia or predictive hyperglycemia. But these are not yet fully automated. And the reason for that is because individuals still need to input into the pump how much bolus insulin is required from the individual at mealtime. So it's essentially each individual needs to manually enter their mealtime bolus insulin. And that could be either done with a bolus calculator, which is through the pump, but the individuals will still need to type in how much carbohydrate they're having at mealtimes. As we saw with each of the CGM technologies, even the hybrid closed loop systems are advancing. One of the latest systems allow for a control algorithm with also a form of artificial intelligence that allows for correction boluses at meal times. And that's using an artificial intelligence system known as fuzzy logic. And when we look at meta-analyses and systematic reviews on outcome data from any sort of artificial pancreas, and here I mean hybrid closed loop systems, AP systems have an increase in percentage time in range, reduced time in hypoglycemia, and reduced time in hyperglycemia. And really just the final question that I had. So in terms of current commercially available hybrid closed loop systems, which of the following statements would be the most appropriate or correct? So these hybrid closed loop systems can achieve percentage time in ranges of greater than 90%. They completely take away the burden of diabetes. Freestyle Libre 2 can be effectively used within a hybrid closed loop system. There is still not enough evidence to support the use in reducing hypoglycemia in people with type 1 diabetes. Or hybrid closed loop systems should not be used during acute hospital admissions while people are unwell. Amazing. Correct answers across the board. Great. So just to go through these. So currently commercially available hybrid closed loop systems really are achieving greater than 70% time in range. They do not take away the burden of diabetes completely. Freestyle Libre 2 is not real-time continuous glucose monitoring, and therefore it cannot be used within a hybrid closed loop system. And certainly I did mention that we've already seen that there is plenty of evidence to show that these closed loop systems can reduce hypoglycemia. And the correct answer, as you all got, was that these should not be used in the acute hospital setting whilst people are clinically unwell. So when people come into hospital, and if they're within an auto mode, using a hybrid closed loop system, then they should come out of the auto mode and then you would look to see whether they would meet the criteria for either continuing on a pump separately or on CGM separately. And finally, just to summarize, I think I've already touched upon this. I think this is a really rapidly advancing field and very exciting time in the diabetes world. However, it does come with its challenges. Certainly, there is that risk of failure of technology. It requires individual input, and I think there is a lot of support that's required from us as clinicians in supporting individuals with diabetes with this technology, because using it in itself can be a significant burden. In terms of inpatient management, I think where possible, allow for self-management. However, if they are in DKA or any hypoglycemic emergency, unwell, then remove the insulin pump, switch to, certainly if they're in DKA, they need to be on a fixed rate insulin infusion, but they should be continued with standard capillary glucose monitoring. And I think the DTN guidelines, which I've shared the link for there, are incredibly helpful for individuals who are hospitalized with pump therapy. And I think the JBDS guidance, which I mentioned earlier, hopefully, I think when they come out, I think they will be incredibly helpful as well. Thank you, and very happy to take any questions.
Thank you very much, Parry. If anyone has any questions, again, feel free to unmute themselves, or if you want to post in the chat. Thank you. That was a really clear presentation with some really, I guess, key insights actually into diabetes technology. It is a really exciting time, but I think you raised a really key point about how do we make sure that those people who previously would have qualified for diabetes technology within type 1 are not forgotten about. And I guess things about, diabetes technology access and equality of access. I think that's probably going to be the next challenge, isn't it? As we get more and more technology, I think that will be a challenge.
Absolutely, I think that's particularly key. And making sure that even not just starting these individuals on the technology itself, but it's really supporting them in terms of how to interpret that data, how to make the most use of their technology. And as great as I think CGM is, I think there can be a real burden of alerts and alarms, as well as burden of hypoglycemia or hypoglycemia aversion that can go with it. So I think there's a lot of support that these individuals do need, and I think it's just about making sure how we as a whole team can really support that.
Yeah, you're right. And how does that need to happen exclusively in hospital, or could that happen to some extent in primary care? It's a bit of an unknown, isn't it?
Yeah, I think the newer technology systems, I think there's a bit of a lack of data in terms, and there is actually a lot of data coming out, and actually thanks to COVID, I have to say, and I'll come back onto the point, but essentially there's a lack of, I think there are a lot more studies that need to be done within the hospital setting itself. COVID has been helpful because I think a lot of people, a lot of studies got approved during the COVID time to try and reduce individuals or nursing staff having to go in and check blood glucose levels and things like that when people had COVID. So it does mean that there is more data coming out from some of these studies, which I think will be very informative in terms of determining future outcomes. But as you say, I think some of that can certainly happen as an outpatient. Not all of it needs to be as an inpatient.
Okay, does anyone have any other questions? I can't see anything in the chat, but I'm sure Harry's put her email addresses up. So feel free to email her. And thank you very much again.
Thank you very much.
So, if you just bear with me 1 second. Okay, sorry about that. Okay, so this is the QR code for today. So I'll just give you, it will come up again at the end, but if you'd like to take a photo of that now, you can. Just give it another 10 seconds or so. Okay, so as I mentioned at the beginning, I'm Harriet, I'm one of the diabetes endocrine registrars, and I thought today I'd take us through a real life case and just get us thinking about cardiovascular and renal protection in type 2 diabetes. So this was a referral from primary care that came to the diabetes clinic at Charing Cross, I would say about 6 weeks ago. And this was the sort of clinical information that was received. So it was a referral for a 66-year-old gentleman with gradually increasing albumin creatinine ratio in the last essentially 3 years, despite very good diabetic control and maximum dose ARB, so angiotensin receptor blockade. He'd actually only been or had type 2 diabetes for essentially 7 years, so would have been diagnosed at around the age of 59. He was on metformin, 1 gram twice a day. He'd had a latest A1C of 39, having been 52 at diagnosis, recent blood pressure of 140/75, and he had a BMI of 28, putting him in the overweight category. So he was on the following medication, so maximum dose losartan, was on metformin, suvastatin, was on amlodipine 10 milligrams, bisoprolol low dose, and acetamib. He had quite a long history of smoking. There was no history of retinopathy. I'm unsure about any cardiovascular history per se, and he was fully compliant with all medications. So he'd had, as mentioned, this raised albumin creatinine ratio of between 8.7 and 10.4 milligrams per millimole over the last 3 years. Unfortunately, we didn't have one from the point of diagnosis. He had a creatinine of 101, giving him an eGFR of 67. And again, that was 80 at diagnosis. He had well-controlled cholesterol. And as I mentioned, he had an A1C of 39. So before moving into renal information, I just wanted to talk about type 2 diabetes remission and just ask a quick question of everyone about what is the definition of type 2 diabetes remission. So, and there are 4 options. So is type 2 diabetes remission an A1C level below 48 for at least 3 months on or off medications? Is this an A1C below 48 for at least 3 months off medication? And again, the same, but for 6 months. So an A1C below 48 for 6 months off medication, or just irrelevant of medication. So I will, hopefully you can all see that screen and okay. So thank you to the people who voted. So the correct result is actually an A1C below 48 for at least 3 months off all medication. So that was the definition that was agreed last summer. And really, in part, that's because a really important part of being in remission for a patient with type 2 diabetes is the fact that they're not taking medication. And I mentioned his blood pressure was 140/95. So what is the target clinic blood pressure? So is it less than 140/90, less than 135/90, less than 135/70, or less than 120/80? Okay, so yeah, the 3 people who voted for less than 140/90 are correct. So, and that's really going off the NICE guidance, who do add the caveat that if a patient has CKD with an ACR of 70 or above, and we should be aiming for a clinic systolic below 130, target range 120 to 129, and a clinic diastolic below 80. I'm not entirely sure why they chose an ACR of 70 as their cutoff. It doesn't seem to correlate with the categories of albuminuria that we use. KDIGO suggests actually that for anyone with CKD, we should be quite aggressive about systolic blood pressures, aiming for less than 120. However, NICE have not adopted that. So when we talk about albuminuria, historically, you may have heard the terms micro and macro albuminuria used, but we're trying to move away from that and instead characterize albuminuria into 3 categories. In the UK, we use milligrams per mole. The US tends to use milligrams per gram. And essentially, patients in the A1 category are classed as normal to mildly increased, so it's not an entirely physiological state. In A2, which our patient falls into, they have an albuminuria between 33 and 30 milligrams per millimole. And then traditionally, what you might have thought as sort of nephrotic range or macro albuminuria would be in the A3 range or severely increased. And when we think about testing for microalbuminuria, how do we essentially confirm that a patient has the presence of albuminuria? Well, really, we need to take 3 samples. We need to make sure that there are no conditions that may invalidate urine albumin excretion, including menstruation, symptomatic UTI, exercise, and sepsis. Harry, I can see that your hand is up. Why don't you unmute?
Sorry, Harriet, it was just to mention that we can't see your slides as we still have the Menti.
Okay, I'm sorry about this. I'm not sure why it's done that. Okay, can you see now? I'm going to stop.
Not yet.
I'm going to stop sharing. I'm sorry about this, everyone. I might just run through can you see now?
Yes.
Okay, so hopefully you caught that about the albuminuria. That's just essentially the albuminuria categories in a table. So we can see that A1 is less than 3, A2 is 3 to 30, A3 is above 30. And you might class this patient as having moderately increased albuminuria. So just in terms of thinking about, how do we essentially know that this patient has albuminuria? Well, we really need to take a number of samples to be sure. So essentially, we should take 3 samples, and if 2 or more are positive, then essentially we can class this patient as having microalbuminuria. We do need to make sure that patients don't have any conditions at the time that the sample is taken that may invalidate it. And those include menstruation, in particular symptomatic UTI, exercise, and sepsis. The literature does talk about, and the guidelines really advise a first morning void urine sample, and that's to avoid the effects of upright posture, so orthostatic proteinuria. And we know that there's little intra-individual variation when samples are taken at this time. However, I'm sure that we all know that most of the time these are just going to be random samples, because actually it's easier just to ask a patient after clinic to provide a sample. So how do we think about CKD with or without diabetes? So this is essentially the nomenclature that's used by KDIGO, and it's used really in all their guidelines. And essentially, we think of eGFR as the measure of kidney function, and then albuminuria as a measure of kidney damage, albeit not a particularly sensitive marker. So you can have normal albuminuria, so essentially A1 and still progress to end-stage renal failure. But once you have evidence of albuminuria, your risk at any eGFR of progression to end-stage renal failure is higher. And that's including for those people who have, a normal or slightly mildly decreased eGFR. So I wanted to ask you, and I don't think there's necessarily a kind of right or wrong answer here. So we've got a type 2 diabetic who's been referred really because of concerns about albuminuria, which seems to be persisting despite ARB treatments. They're overweight, they're a smoker, blood pressure is acceptable within the guidelines, and a good HbA1c. So what should we do here? Should we say that we're going to optimize their cardiovascular disease risk factors and just monitor? Are we going to do that and start an SGLT2 inhibitor? Are we going to optimize risk factors, start a GLP-1 analog? Are we going to think about a non-steroidal mineralocorticoid antagonist like finerenone? Are we going to do a Q2/3 score for cardiovascular risk, and based on that think about an SGLT2 inhibitor? Or are we essentially going to say that this is not a sugar problem and refer on to renal? Okay, so for people, so essentially the majority have said that they would start an SGLT2 inhibitor. We've had one person who will optimize cardiovascular risk factors and one do a Q risk score. Okay, so we'll come back to that question. I just thought I'd just mention a little bit about diabetic nephropathy. So just a reminder that really the damage is exerted on all compartments of the kidney. So the glomerulus, the tubules, the vasculature, so afferent and efferent renal arterioles and the interstitium. And really renal fibrosis is the final common pathway of diabetic nephropathy. So this fibrosis is a product of multiple mechanisms, including renal hemodynamic changes, glucose metabolism abnormalities associated with oxidative stress, and inflammatory processes, as well as an overactive renin, angiotensin, aldosterone system. And traditionally, the disease progression of diabetic nephropathy involves various clinical stages over a number of years. So hyperfiltration leading to micro and macro albuminuria, although we're not really meant to use those terms, with progression to end-stage renal failure. And I think it's important to mention that most patients or individuals with type 2 diabetes and CKD die due to cardiovascular disease before progressing to kidney failure. So this is just some data from the UK prospective diabetes study. So that was a landmark randomized multi-center trial of glycemic therapies in 5,000 patients who were essentially recruited within 6 months of a diagnosis of type 2 diabetes. It ran for 20 years between 1977 and 1997 in 23 UK sites. And this was at a time really when ACE inhibitors were not standard of care. And the study in itself really showed that improving blood glucose and or blood pressure control did reduce microvascular and to a lesser extent macrovascular complications. And essentially what we know after a median of 15 years after diagnosis of type 2 diabetes, about 40% of participants had developed albuminuria and 29% developed renal impairment. But what they found really was that a substantial proportion of patients developed one outcome but not the other. So of those patients who did develop renal impairment during the study, 61% did not have albuminuria beforehand, and 39% did not develop albuminuria during the study. And of the 1,500 patients who developed albuminuria, 12% developed renal impairment before developing albuminuria. So there is this concept of silent diabetic nephropathy. So several studies since then have reported substantial kidney function decline in patients with diabetes without albuminuria or proteinuria. And there was quite a large study in 2006 that examined and graded renal histologic findings from autopsy from quite a cohort of patients with diabetes and correlated them with clinical manifestations of diabetic nephropathy. And actually, albumin or proteinuria was not associated with the presence of histologically proven nephropathy. And there was a high proportion of clinically undiagnosed yet histologically proven nephropathy. However, at baseline, it does look like albuminuria does in itself predict the risk of progression onto end-stage renal failure, as we saw earlier from the heat map from KDIGO. So this was the chronic renal insufficiency cohort study that reported in 2018. And this is just showing some Kaplan-Meier plots of the cumulative hazard of end-stage kidney disease by baseline 24-hour urinary albumin excretion. So essentially they took 1,900 participants. Now these patients did actually all have an element of CKD, so mild to moderate with an eGFR 30 to 55, and followed them for a median of 7 years. And this prospective study did show that those people with diabetes and CKD and normoalbuminic CKD had a much lower risk of progression on to CKD, and they had a much slower decline in their eGFR. So generally, as a marker of progression, diabetic chronic kidney disease, albuminuria is used, but it does have high variability, low sensitivity. It can spontaneously regress, and it doesn't necessarily track with the eGFR. I think it's just important to remember that there can be coexisting vascular disease within the kidneys or tubulointerstitial fibrosis that are the predominant processes, or that the eGFR decline may have resulted from a previous episode of AKI, either recognized or subclinical. So why else are we concerned about the presence of albuminuria? And that's because of albuminuria as a risk factor for cardiovascular disease and cardiovascular mortality. So these are some adjusted hazard ratios, again, taken from KDIGO, and the 3 lines represent separate ACRs. So A1 or normoalbuminuria is the blue line. The A2, so albuminuria of 3 to 30, is the green, and red line is above 30. And what we can see is that really for any given eGFR, once you have A2 or A3 albuminuria, there is really an increased hazard ratio of cardiovascular mortality. So it's really been established since sort of 1984 that microalbuminuria is a cardiovascular risk factor in people with type 2 diabetes. It seems to be a significant and independent cardiovascular risk factor across the general population. The Heart Outcomes Prevention Study in 2001 showed that really any degree of albuminuria is a risk factor for cardiovascular events in individuals with or without diabetes. And to date, the main thinking as to why it is a factor is related to something called the Steno hypothesis. So this was coined by a research group at the Steno Hospital in Denmark in 1989. And this hypothesis is essentially that glomerular dysfunction is reflective of extensive vascular damage throughout the body. So if you think in the middle in diabetes, you have chronic inflammation, oxidative stress, insulin resistance, and RAS activation. And albuminuria is really just a surrogate marker for all of that. And that these patients really have angiopathies in many organs, leading to atherosclerosis, stroke, ischemic heart disease, and sudden cardiac death, as well as kidney disease. So just to mention this patient's medication, so he's already really on maximum dose of sartan. He's on amlodipine, bisoprolol, statins, acetaminophen, metformin, and currently the people who voted most wanted to start an SGLT2 inhibitor. Now, in terms of giving an ARB or an ACE for any patient who is diabetic with any evidence of albuminuria, you really want to make sure that you're titrating to the maximum dose, that you're not really titrating to blood pressure. And in terms of SGLT2 inhibitors, purely in terms of thinking about their effect on albuminuria, or actually maybe before I did do that, of the people who voted for an SGLT2 inhibitor, does anyone want to say why they voted for that option? No. Okay. So the original cardiovascular outcome trials had renal outcomes as secondary. So post hoc analysis of the main cardiovascular trials did show renal protection at all stages of albuminuria. And then since then, we've had Credence and DAPA CKD, which recruited patients with quite high urine ACRs, and EMPA kidney trial, which essentially about half had an EGFR, sorry, an ACR between 20 and 30. And so what we can see here really is that they really were looking at quite different populations. There was a trend towards the highest risk reduction for MACE in those with macroalbuminuria, sorry, A3 albuminuria at recruitment in the original trials, but really these were trials that were looking at patients in the A1 group. So the other reasons you might want to think about starting an SGLT2 inhibitor in this patient is because, of course, we know that an SGLT2 inhibitor has additional effects. It doesn't just help with the effects of hyperfiltration within the kidney, as I'm sure you're aware, and I've just highlighted some of them on the slide. And there's a slight discrepancy in the current guidelines. So the 2019 European Society of Cardiology guideline provides a class 1 recommendation to use SGLT2 inhibitors for patients with type 2 diabetes and established cardiovascular disease, or those at high or very high risk. So that includes patients of target organ damage such as CKD. The latest KDIGO guidelines, which are out for, or guidance, which is out for consultation, does recommend SGLT2 inhibitors really for most patients with CKD, provided that their EGFR is above 20 or thinks that they'll get benefit, but does talk about this high priority features group, so those particularly with an ACR of above 20 in our units, that's the American units, or heart failure, and that's really because the renal benefit seen for patients with less albumin excretion comes from cardiovascular outcome trials with secondary kidney outcomes, and those really that had primary renal outcomes were those that had much higher albuminuria. And this is just, as I mentioned, these are the cardiovascular risk categories that are found in the European Society for Cardiology, which the British Society for Cardiology also uses. And here, those who are at very high risk are patients with diabetes, as I mentioned, established cardiovascular disease, target organ damage, including proteinuria, or 3 or more major risk factors. Does anyone have any questions at the moment? I'm just going to check in the chat. Okay, so just moving on to talk a little bit about mineralocorticoid receptor antagonism. So we know that in the heart, MRAs improve coronary vasodilatation and left ventricular perfusion, so well-established use in heart failure. In addition, the steroidal mineralocorticoid receptor antagonists reduce albuminuria, but their effects on kidney disease progression, so EGFR decline or kidney failure, have never really been examined in large trials, and hence their benefits on clinical kidney outcomes remain uncertain. In particular, trials have always been marred by significant hyperkalemia when they've been combined with ACE inhibitors and ARBs, but they have been identified as receptors as a target for potential treatment. We know that receptors are present on fibroblasts, podocytes, and endothelium of the kidney. So aldosterone is increasingly recognised to contribute to an inflammatory response in kidney disease that's independent of blood pressure. We know that patients on maximum dose RAS blockade can essentially have incomplete receptor blockade, or they can have ACE inhibition that's bypassed by angiotensin formation from chimeases. Dual inhibitor therapy has never been successful. We know addition of renin inhibition hasn't prevented cardiovascular and renal events, and chimase inhibitors did not reduce albuminuria. There's also a concept of aldosterone breakthrough, where patients, despite having the long courses of RAS, seem to have supraphysiological levels of aldosterone. And as mentioned, studies combining RAS and steroidal aldosterone antagonists seem to produce unacceptable hyperkalemia in clinical trials. So just thinking for a second about mineralocorticoid receptor antagonists, you've got your first generation. So think about spironolactone, has low specificity for the receptor and lots of side effects. So, we all know about gynecomastia, also causes hyperkalemia. Second generation MRAs were more selective for the MR, but had much lower affinity. So they had reduced adverse effects, but limited clinical efficacy. And then the newer generation of non-steroidal MRAs, so in particular finerenone, which has a high, which is potent, it has a high selectivity for MR and seems to also accelerate the MR degradation process. From my reading, it seems like the non-steroidal MRAs also bind to the MRs in a way that they inhibit the recruitment of transcriptional cofactors involved in the expression of pro-inflammatory and pro-fibrotic genes. So just to mention, there's been 2 large clinical trials looking at their effects. So these trials both enrolled people with type 2 diabetes and CKD who were treated with standard of care at the time of the trials were initiated, including a RAS inhibitor and any other appropriate medications to control glycemia and blood pressure. About 8% of them were on SGLT2 inhibitors. And this is because they weren't really standard of care when the trials were recruiting. Fidelios DKD showed that finerenone slowed the progression of kidney disease and improved cardiovascular outcomes in patients with predominantly advanced CKD and type 2 diabetes. And Figaro DKD showed that finerenone reduced the risk of cardiovascular events in patients with mild to moderate CKD and type 2 diabetes. And so on the back of this, KDIGO recommends that non-steroidal MRAs can be used in patients on maximum tolerated ASIs or ARBs with an EGFR of 25, with a normal potassium and persistent albuminuria. And they have stated in their guidance that in general, an SGLT2 inhibitor would be initiated prior to finerenone. Just to mention GLP-1 agonists, so they will have, we know that they have beneficial cardiovascular effects and they can reduce albuminuria, but in terms of where KDIGO places them, they really are very keen to push SGLT2 inhibitors as first-line therapy and really talk about GLP-1 receptor agonists in patients who particularly want to lose weight or where glycemic control is needed. And then I just wanted to finish really with the figure, or this figure essentially that shows the approach that KDIGO advises for patients with diabetes and CKD. So you can see in green, you've got the type 2 diabetes pathway, and then green and blue is type 1 diabetes and type 2 diabetes, really pushing SGLT2 inhibitors up front. At the moment, non-steroidal MRAs are only license, I think, for type 2 diabetes, and it'll be interested to see in real world data if actually there is less hyperkalemia. That's traditionally been the concern about starting MRAs in these patients. The studies were very selective about the patients that they used. And we have one study that compared spironolactone and finerenone head-to-head in CKD patients, and this showed only a slight difference in potassium concentrations. So in terms of what actually happened to this patient, so there was quite a lengthy discussion in the post-clinic meeting, and actually it was decided that there was some wiggle room really that we could improve his cardiovascular risk factors, so we could essentially get him to stop smoking, get him to lose weight. There was still some room to improve his blood pressure, and that we would review in 6 months' time and then think about further treatment. I mean, if you were to look at his Q risk score at the time that we saw him in clinic, he would score quite highly in terms of thinking about cardiovascular risk and the risk of a cardiovascular event in the next 10 years. And actually, even if you put in data such that he's a normal weight with good blood pressure and an ex-smoker, he would still have a significantly high cardiovascular risk on the Q risk 2 scoring system. So I think there's a good argument to just go ahead and start an SGLT2 inhibitor now. I'd be really interested to hear other people's thoughts on this. I don't know if anyone wants to contribute. No, all quiet. Okay, does anyone have any questions? I appreciate that was quite a lot to get through. Okay, in which case I'll move on to this is the QR code again.
Thank you, Harriet. Finerenone, brand new drug,